Welcome to the THOR Table of Knowledge podcast, where we dive deep into the groundbreaking world of trauma care, hemostasis, and oxygenation research. A special thank you to our sponsor, Leukocyte, for their support. Leukocyte is revolutionizing trauma care with their innovative frontline ODP spray-dried plasma system, with the goal of empowering blood centers worldwide to produce dried plasma for transfusions.
In this podcast, we're going to discuss the merits and limitations of using leukocyte reduction with a platelet-sparing filter for whole blood. So, Dr. Kapp, the industry has started to leukocyte reduce whole blood with a platelet-sparing filter based upon, I guess I would say, historical data or dogma focused on the benefits of leukocyte reduction. Can you give us kind of a review of the data on leukocyte reduction and its benefits, potential benefits in this population?
Sure. So historically, one of the challenges in transfusion medicine has been patients' reactions to transfusions. And if every medical student has studied this problem, you give a transfusion, patients might get something like a fever or an allergic reaction or whatever. And basically, what people determined was that a lot of that was being driven by the white cells in blood releasing inflammatory mediators. So the thought was if you remove those before you store the blood, you will have less likelihood of having febrile non-hemolytic transfusion reactions. In addition to that, was observed in the hematologic malignancy literature that some patients who had not been previously exposed to leukotropic viruses like cytomegalovirus could basically get infected with CMV, right, from the transfusion of infected white cells in a transfusion. So basically reducing the risk of CMV transmission in immunocompromised patients was another major driver. But really what the history of leukoreduction has shown us is that the biggest single benefit is just reducing the number of fevers in stable patients. So if you're in an outpatient clinic setting, let's say, and you have oncology patients you want to transfuse and somebody gets a fever halfway through their red cell unit, now it's a big workup. And the patient's got to sit there and get blood cultures and all the things. As you're worried about a septic transfusion, you have to rule that out. By leukoreducing it and you reduce the frequency of those kind of reactions, it increases transfusion efficiency in mostly that outpatient setting.
So historically, the benefits of leukocyte reduction of either red cell units or now whole blood has been less alloimmunization, less CMV transmission, as well as less febrile transfusion reactions.
That's basically the main thing.
But what about clinical outcomes? What is the data on clinical outcomes, whether it be survival or organ failure, even infection risk? What's the data tell us?
So outside of those leukotropic viruses in patients who, by the way, have not previously had CMV, and the prevalence of CMV in the population is extremely high. So this is a really limited, benefit. Basically, there's not a lot of clinical benefit, particularly in patients who are sicker. So for example, in severely bleeding patients, leukoreduction has not been shown to have any impact whatsoever on any clinically meaningful benefit. Not infection risk, not even fevers, not thrombosis, other measures of organ function, loss of organ function, and certainly not mortality. So in bleeding patients, really the population that the THOR network is focused on, patients in shock, due to trauma or other reasons for major bleeding, leukoreduction has not panned out to be useful.
So for patients with severe life-threatening bleeding, would there be a benefit to not leukocyte reduce with a platelet-sparing filter? What are the reasons to not do it?
Right. So just to review for the audience, in case they're not tracking this, most leukoreduction filters remove all the platelets. So that would clearly be a problem because we know that giving platelets back helps with hemostasis, helps stop bleeding, helps patients with severe bleeding. So you definitely want the platelets there. So you would have to use a platelet-sparing leukoreduction filter, of which there is only one on the market. So with COVID, everybody experienced all kinds of supply chain shocks and realized that having that vulnerability to a single product, a single supplier, could could impact also, blood center operations and availability of the product. So that's one, at least theoretical problem that could be solved by not leukoreducing. The other thing is, frankly, leukoreduction filters are not free. There's a cost to doing it, both in terms of paying for the filter. The current set that is used is actually meant for processing blood into components. So if you're using it for whole blood leukoreduction, you're throwing away most of the kit that's involved. So it's a plastic waste, it's a waste of money. And you have to perform the leukoreduction within 8 hours of collection, which is a real challenge operationally, because if you do remote collections, at the local high school or whatever, or somebody's workplace, and try to bring the product back within 8 hours and process it, that frequently is not feasible. And so you basically are reducing availability of the product, in particular whole blood, by demanding leukoreduction. So cost, efficiency of operations, waste, all big problems. The other thing is, the current kit that's available that spares the platelets uses CPD as an anticoagulant, citrate phosphate dextrose, which has a 21-day shelf life for whole blood. So you're limited to 21 days. Now, if you used the anticoagulant CPDA without a leukoreduction filter, then you could potentially have a 35-day shelf life, which would increase, availability of the whole blood. So that's a potential benefit.
Right. So, and the other potential benefit that you didn't bring up is, and that many people discuss, is that with a platelet-sparing filter, while it spares platelets, it does remove about 20% of the platelets.
Right.
And many people are concerned about that, and a potential reduced hemostatic function with a leukocyte-reduced whole blood product with that platelet-sparing filter. The evidence, though, out to 21 days of storage is fairly minimal when people look at function, not platelet count. There are some studies, and we've published a few of them, that show at certain time points, closer to the 14, 21-day time point, that there's slight, reduction in platelet function too with the leukocyte reducing filter. But that does make you think about then if the community transitioned to mainly using a non-leukocyte reduced blood product that went out to 35 days, then what are the unintended consequences on hemostasis with that product going past 21 days out to 35 days? And there's interesting literature showing that the function does continue to decrease past 21 days. And are you worried about that potential reduced hemostatic function? Because at least from my perspective, it seems like we are potentially repeating the sins of our fathers when it comes to the storage lesion.
So I think, your data from Iraq back in 2009 compared fresh whole blood used basically immediately after collection to component therapy that included platelets, and the survival benefit was massive. And I think that shows that the fresher the product, you are likely to have a better outcome, right? I don't think any of us, if given the choice of being resuscitated with 35-day, whole blood versus fresh, warm whole blood from a donor, would choose the 35-day product, right? But so I think how we use these products has to be, first of all, we should be studying this. I agree with that. But also, we have to look at what risks patients face in what settings and what's appropriate for what setting. So if you think about the far forward, remote battlefield, long evacuation time in the pre-hospital setting, where your options might be saline or 35-day whole blood. I'll take the 35-day whole blood every day, because even though the hemostatic function and the red cell function decreases with time, it's still better than salt water, right? Pasta water. We don't want that. Is it better than just red cells and plasma together? I mean, the in vitro data suggests that you still get a little bit more function in terms of at least viscoelastic, testing capability from whole blood at the end of storage compared to just red cells and plasma with not any platelets added whatsoever. Now, for the inpatient setting where you do have other options, well, I think, being patient focused and trying to optimize outcomes for your particular patient with the products you have is the way to go. So if you have fresher whole blood, you should use that. You can use 1:1:1. There are many things you could do. If all you had was whole blood and some of it was closer to expiration, you could do a blend of younger product and older product to try to achieve an overall more hemostatic mix for the patient, if you will. I think the bottom line is figuring out exactly what the right answer is for each of these settings is going to require some clinical study, and that's what we should be doing.
Right. I agree. And there are, though, parts of the world, right, where leukocyte reduction is mandatory, required. So for countries where it's just not an option for them, do you feel it's still safe for them to, with a platelet-sparing filter, to leukocyte reduce whole blood? Is it a reason not to use whole blood, or should they just follow their regulatory approach? And is it still safe to use it if that's what's required?
I think it's safe to use. You are clearly paying a price, literally in terms of cost of the product, for really no significant benefit. But if it's required, it's safe. You're losing a few platelets. You might ultimately end up using more platelets to resuscitate those patients, but it's safe.
So in summary, it sounds like what you're saying is that there isn't any clinical outcomes data supporting the requirement to leukocyte reduce whole blood, or even red cells for that matter, for patients in hemorrhagic shock. And if it is required in a region or in a country, that it's acceptable to use, but not optimal.
Right. It's not. I think that basically, in a world of constrained choices with limited resources available for healthcare, you have to ask yourself the question: is this worth doing? But if it's required, it's safe, it's fine. But understand that you're probably not getting much benefit from it.
Great, thank you.
That's a wrap for this episode of the THOR Table of Knowledge podcast. A big thank you to our sponsor, Velico, for supporting the advancement of trauma care. Their frontline ODP spray-dried plasma system is paving the way for blood centers globally to produce potentially life-saving plasma for transfusions. Check out our website, www.thornetwork.com, for more podcasts, and join us next time as we continue to explore the cutting-edge science of trauma, hemostasis, and oxygenation. Until then, stay safe and stay informed.